Hello everybody, today we are going to discuss about an important topic which is metabolic response to injury and shock. I'm Dr. Jignesh Gandhi from Mumbai. The topic is interrelated because unless you know what is happening in homeostasis, it is very difficult to understand what happens in a state of shock. So we will be going through the components of the responses, the mediators of the responses, the phases of responses and the key components, the factors which are aggravating and preventing these problems, and finally we'll be discussing about shock, and then we will be taking a couple of MCQs at the end of the session. This is a picture from the Shushruta era, and you can see how the patients were treated during that time because of the injury. A similar picture in the old centuries about how there's a magical potion in the hand of the gentleman on the right side and how the patient is getting treated, or a case here where there's a bleeding wound and there are a couple of people who are there to salvage the patient's limb, or here how an amputation has been performed and the patient has been bleeding and how he's been revived later on. So there has been a significant evolution in terms of treatment of metabolic responses and trauma. Here you can see in the modern era the surgeon being performing and everyone watching what's happening there. So in the olden days, the concept was that if there was any trauma or injury, the patient was put at rest. And this led to healing, but in the bargain, you had to compromise with anorexia, and there was a severe catabolism which occurred in these patients. And this is a state of the patient after the injury was completely healed. You can see a patient has literally gone into a complete starvation. So homeostasis means to maintain constant conditions in an internal environment. The organ and the tissue perform functions to maintain this constant condition. So there has to be an act where there has to be a continuous balance and a good perfusion to the tissues all the time. Now look at your chart here. So if you start here with this particular thing here, that whenever there's a stimulus and the blood glucose rise, after we eat something, then there is a secretion of the beta cells in the pancreas to release the insulin into the blood. And this insulin then subsequently has twofold action. One, it leads the body cells to take up the glucose. And here in the second part, you can see that the liver takes up the glucose and it keeps on storing it. So this additional part is been stored to be utilized later. And by this, what happens is that blood glucose level declines and then you go into the stage of homeostasis. Similarly, in a second situation where you have the blood glucose level which falls, typically it happens when we are starving. This leads to alpha cell secretions in the pancreas, and that leads to secretion of glucagon. And now what the glucagon does is that in the liver, whatever was the stored glycogen, it will break down to release the glucose, and thereby the blood to glucose level comes up and we will go to a set point of what is known as homeostasis. These are all the counter regulatory mechanisms which work in different systems like the hypothalamic pituitary axis. Then you have the renin-angiotensin and several others. So it's very important that we understand the homeostasis which acts in all these systems so that we can understand the physiology well. Why does this happen? It happens because the tissue function has to be restored and you have to eradicate the causative organisms causing this problem. In elective surgery or minimal invasive surgery, there is a reduced injury, so there's a reduced effort by the body to reach to a stage of homeostasis. While in emergency surgery, there is artificial homeostasis in form of resuscitation. So we try to bring the parameters normal by giving several support system, including organ support system in a critical care unit, thereby achieving a homeostasis. Look at this patient where there is a minimal invasive surgery being performed for a complex hernia, and you can see here that this patient definitely will recover much better compared to this patient who has undergone about 5 to 6 hours surgery for a complex abdominal wall reconstruction, and this patient will take a long time before it comes back to homeostasis. In the basic concepts of homeostasis, it is a foundation of normal physiology. A good perioperative care helps in good surgical outcomes, we all know, and that happens in elective surgery. While in emergency surgery, you need resuscitation, critical care, and surgical interventions all will help to restore homeostasis in a severely injured patient. What it tells us is that when you have a complex trauma patient, a complex patient with a complex surgery, That time we need a lot of artificial modality of treatment to get the patient back to homeostasis. So the basic concept is to have a stress-free perioperative care to help preserve the homeostasis following the surgery. What are the neuroendocrine responses to injury and critical illness? They are biphasic. One is an acute phase, which is characterized by actively secreting pituitary and elevated counterregulatory hormones like cortisol, glucagon, and adrenaline. And these changes are thought to be beneficial for a short term survival. While in the chronic phase, it is associated with hypothalamic suppression, low serum levels of respective target organ hormones, and these changes contribute to chronic wasting. So that's what we saw in the good old days. There used to be a chronic phase, and the patient used to undergo severe catabolism. Look at this picture here. This is an integrated response to injury, and you can see several things which happen in the plasma, and that leads to changes in the body metabolism. For example, increase in ACTH and growth hormone leads to increased adipocyte and lipolysis. There is increase in adrenaline, increase in cortisol levels, increase in glucagon levels. So all these things, and even the increase in the interleukin levels, the interleukin 1, 6, 8, all will lead to pyrexia and hypermetabolism. What are the systemic inflammatory response syndrome following major injury? It is driven by pro-inflammatory cytokines, for example, IL-1, 6, and tumor necrosis factor alpha. And it is followed rapidly by increased plasma levels of cytokine antagonists and soluble receptors. If prolonged or excessive, may evolve into a counter-inflammatory response syndrome. So you can see here that the body always tries to put in a controversy or a balance between a pro-inflammatory and an anti-inflammatory status. What you see on your right side are the anti-inflammatory interleukins, and what you see on your left side are chemokines or pro-inflammatory. And the body always try to see that the pro-inflammatory status is lesser, and then you have more anti-inflammatory status. This is again an example of an immune system where you can see a classical example this of is pancreatitis, which I also call it as an immunomodulatory disease. Here you have the anti-inflammatory markers and the pro-inflammatory markers, and the idea is that how we can control on the pro-inflammatory markers by various mechanisms so that these patients of acute pancreatitis will not go into a stage of necrotizing pancreatitis. This is a classical model. If someone has to understand the concept of immunology well, pancreatitis is a great example. Again, here you can see the balance between the anti-inflammatory and the pro-inflammatory. So what are the physiological responses to the injury? The natural response to the injury include, what we saw initially, that there is immobility, leads to anorexia and catabolism, and these are designed to aid survival of moderate injury in absence of medical intervention. So in the good old days when the intervention was not possible, these three things led to the survival, but in the bargain, the patient underwent a severe catabolism. Again, this is the major catabolic and anabolic signaling pathways in the skeletal muscle homeostasis. So every system in the body has a very complex homeostatic mechanism. There is something which is known as when you have an injury, you have a process going on in the hours initially, or a state of shock, which is also known as the F phase. Followed by that, you have a catabolism phase, which goes in particular days, also known as a flow phase. And then finally, you have the recovery where the anabolism occurs, and then this is also happens in few weeks. So from few hours from F phase, we move on to the flow phase and we move on to recovery. And likewise, there's a condition of shock followed by catabolism and followed by anabolism. The shorter you can make this duration, it leads to faster recovery of the patient. So what is the purpose of the neuroendocrine changes following injury? This constellation of the problems which occur, they're essential to provide substrates for survival. They would postpone anabolism and they would optimize the host defense. These changes may be helpful in the short term, but it may be harmful in the long term, especially when you have a very severely injured patient who otherwise would have not survived without medical intervention. Hypermetabolism following injury, it is mainly caused by an accelerated of energy dependent metabolic cycles, and is limited in modern practice on account of elements of routine critical care. So you can see here what are the metabolic response to the injury. On the left hand side in the peripheral tissues, you have the muscle, adipose tissue, and the skin, and thereby there is the liberation of amino acids. And in the central tissues, this is where it gets reutilized and deposited. So one of the main reasons why the reutilization of amino acids derived from muscle proteolysis, it leads to net catabolism, and that is increased glutamine and alanine efflux from the muscle, which is derived from there. Skeletal muscle wasting, which we all know provides amino acids for metabolic response of central organ. So when there's a sick patient in the ICU for a long time, what happens is that the muscle wasting comes up very, very fast. And if this is not replenished on time, then these patients can go into severe catabolism. And why it is done is because it needs to support the metabolism of the central nervous system and very vital organs. It can result in immobility, and it can contribute to hypostatic pneumonia, because if you have the muscle wasting in the chest cavity, then the patient's breathing will be poor, and this patient, if he's ventilated for a long time, can go into pneumonia and subsequent death. So this is what happens typically in a patient who is long standing in the ICU on a ventilator. The support of the amino acid is very, very crucial and important. In extreme catabolism, you will have urinary nitrogen loss about 14 to 20 grams per day, and we almost can have about 500 grams of skeletal mass per day, which is lost. Catabolism cannot be inhibited by hyperalimentation, as it is an ongoing process, but a modest dose of TPN probably may do harm in these patients. So one has to be very calculative in what you're going to give in these patients to avoid a skeletal muscle wasting. What are the hepatic acute phase responses? Hepatic are representation of repavation of body protein metabolism. There are positive reactants in form of CRP. So you will find the CRP always raised in patients with trauma and metabolic injuries, while there are negative reactants called albumin, and the plasma concentration of this will decrease when the patient is in state of lot of energy divide problems like injury. Coming to the changes in the body composition following injury. So if you see a 70 kg male, about 13 kg is in form of fat, and the lean body mass is about 57 kg. In that 57 kg lean body mass, you have 3 kg of minerals, 42 kg of water, which is one of the major chunk of in the body, and about 12 kilograms of proteins. And in 12 kilograms of proteins, the skeletal muscle takes away about 4 kilograms. Non-skeletal muscles, they take about 8 kilograms. In the water supply, you have about 28 liters of water which is in the cells, and about 14 liters is in extracellular space. So this is very important for someone to understand how it works. Changes in the body composition following a major surgery. The catabolism will lead to decrease in the fat mass, which we saw on the earlier side, and the skeletal muscle mass, because it needs all that to gain energy. And the body weight may paradoxically increase because there is an expansion of the extracellular space. So in a supra-major post-op patient, if it's a patient in a prolonged ICU, you'll always find that these patients become edematous because there's a lot of shift of fluid from the cellular space to the extracellular space, and thereby you will find these patients become very, very heavy. Hypothermia. This is a very important stage, and this results in increased elaboration of adrenocorticoids and catecholamines. When compared with normothalamic controls, even mild hypothermia can result in 2 to 3-fold increase in the post-op arrhythmias and catabolism. So it's very important today in the modern theaters and the hospitals. You will see that the temperature is always around 22 to 24 degrees centigrade. In the OR, it is also set at one particular point, because we know that if hypothermia sets in the patient much earlier on, it can have a lot of implications in terms of the cardiac problems and also catabolism. And randomized trials have shown that maintaining hypothermia by an upper body force air rating will reduce your wound infections, cardiac complications, bleeding, and transfusion requirements. So a very simple measure of just taking care of the temperature of the patient can lead to very good outcomes. What are the metabolic changes which happen in starvation? So you have an early, an intermediate, and an advanced stage. In an early stage, which is for about 2 days, you will have glycogenolysis. We saw that the glycogen which is deposited in the liver starts getting broken down, and this becomes a source of glucose in the body. Energy is also derived from an alternate sources in the intermediate state, which happens in about 24 days or about 2 to 3 weeks time or more. The glycogen stores mostly are depleted and do not serve as a source of glucose. So fatty acids and ketone bodies, they supply the energy to the heart, kidney, and the muscles. And in an advanced state, which is almost more than 24 days old, the ketone bodies they will supply to the heart is decreased and is limited to the brain only, because the vital of all is the brain to restore everything. The heart, kidney, and muscles essentially rely on fatty acids as the main source, and gluconeogenesis is enhanced due to increased activity of enzymes pyruvate carboxylates of fructose 1,6-biphosphatase. So it's very important to understand what happens in 2 days, in 24 days, and in advanced state, which is more than 24 days. This is a normal foot ankle, and then as you see, it progresses to mild edema. And in the extreme right of the picture, you can see severe edema, which happens in patients in the ICU for a long time because of the fluid which moves from the cellular to the extracellular space. So, avoidable factors that can compound the response to injury. Yes, we can avoid a continuous hemorrhage by being very, very speculative and very clear on what's happening after the major surgery. Prevention of hypothermia, as I told you, just controlling the blood temperature of the patient's body would lead to a significant outcomes. Tissue edema, tissue underperfusion, avoiding starvation and immobility, all these things can compound the injury status. So if you can control, what will happen is you can phase out catabolism much earlier, and there will be an early anabolism. And this is what should be the state of every doctor, that we should try and aim that how we can phase out catabolism faster and we can bring in anabolism much earlier. Again, this is a slide which shows the factors that exacerbate the metabolic response to surgery. So you can see here wound, hypothermia, hypotension, and pain, and that will lead to a cascade of cytokine events and also adrenosympathetic events. Thereby, you will have pyrexia, acute phase responses, insulin resistance. You will have futile substrate cycling and muscle protein degradation, because everywhere the idea is to provide an energy source, which then subsequently will lead to more catabolism, and anabolism will be prevented. This is an ERAS program. So what happens in an enhanced recovery program is by modulating the multimodal responses at every stage. If you see here in the lower part, you can see that it takes from few days for few weeks in the traditional care for to patient to get back to a good functional capacity. While here with ERAS protocol, there are several mechanisms. Like in upper GI surgery, you will probably start the patient on early enteral feed. You'll be giving them antiemetics. You'll be giving them a good gastric emptying medications. And this kind of a multi-modal approach will try to get the patient into early functional capacity. So, what is a proactive approach to prevent unnecessary aspects of surgical stress response? One is to get the patients operated by minimal access techniques. So that means the impact of trauma is small. If the impact of trauma is small, then the patient will recover faster. Blockade of the efferent painful stimuli by giving epidural analgesias, certain nerve blocks, spinal analgesias, wound catheters. Today we also have certain modalities where you can give pain management as per the need of the patient through IV mode. You minimize the periods of starvation. As I told you, early enteral feed by doing an ERAS protocol also helps to lessen the surgical response, and early mobilization. So with the advent of physiotherapy today, you can mobilize the patient much earlier so that your surgical responses go down. Let us now talk about shock. Shock is a systemic state of low perfusion that is inadequate for normal cellular respiration. With insufficient delivery of oxygen and glucose, the cells now switch from aerobic to anaerobic metabolism. And if this perfusion is not restored in a timely fashion, it will lead to cell death. So every word of this particular definition is very, very important for you to understand that there will be a state of low tissue perfusion, and slowly the cells move from aerobic to anaerobic mechanism. And if you do not provide oxygen, glucose, then and the perfusion is not maintained, then it can lead to cell death. Classification of shock, it can be classified into hypovolemic shock, cardiogenic shock, where it is a central heart which is at failure, obstructive shock, distributive shock, and endocrine shock. So if you see, basically these are the four main types. In the hypovolemic shock, you will have a loss of volume, typically happens in patients with trauma. The second entity is a cardiogenic shock, where the main pump is a failure. That means the patient has got a myocardial infarction. Then you have something which is known as an obstructive shock, where there will be a problems with the blood outflow which comes from the heart, and the distributive shock, which happens at the peripheral level, which typically happens in patients with sepsis. So in the topmost, if in a hypovolemic shock, typically happens in the patient with trauma, you'll have hypotension, tachycardia, the pulse of the patient will be thready, and the extremities will be cold, pale, moist skin, and the urine output will be going down. There will be a decreased cardiac output and increase in the systemic vascular resistance, so that it prevents a further blood loss. In cardiogenic shock, also you will have a decreased cardiac output and increased systemic vascular resistance. But here, what will happen is that you will also hear some crackles because of the fluid which gets collected into the lungs, and the patient will become tachypneic because of that. The next entity is a neurogenic shock, where you will have patients which are hypotensive, they will have bradycardia, but there will be warm, dry skin. So, which is a very, very big paradox, which one has to be very, very clear. And there will be venous and arterial vasodilation, which leads to this warm, dry skin. Anaphylactic shock, which happens because of any drug reaction. Here, the patients will have pruritus, urticaria because it's a drug reaction. Patients will get restless. There will be also loss of consciousness. But what will happen is there will be a decreased systemic vascular resistance in these cases. And then you have the septic shock, where there will be hypotension, tachycardia, there will be a bounding pulse. The patient will be pink, warm, with flushed skin. But here, the cardiac output also decreases, and there's also a decrease in the systemic vascular resistance. So distributive shock contributes these three entities, what we saw earlier, the septic shock, the anaphylactic shock, and the neurogenic shock. So all these three together contribute to what is known as a distributive shock. This slide tells you about what happens to the important parameters in each one of them, which we saw earlier. It's a very important slide because you may have a case scenario where these kind of entities will be given to you clinically, and you should know when does a particular thing happen. So in the distributive shock, the systemic vascular resistance will be very, very low, while in all other it will be very high. Just to give you an example. So this is what happens in each one of this shock. In clinical features, again, look at your left side of the screen, you will see that there is a phenomenon of lactic acidosis. So in a compensated shock, there will be mild lactic acidosis. Outputs would be normal, patient would be conscious, and there will be mild tachycardia. While in the milder form of the shock, you will see that the lactic acidosis has increased. There will be tachypnea, and the pulse rate will be very high. While in moderate cases, you will have hypotension which starts setting in. And in a severe condition, you will have patients who will be anuric, they'll be comatose, the breathing would be very labored, and there'll be severe hypotension. So this particular thing can come as a question where you will have a clinical scenario where they may tell you a scenario whether the patient has come in a condition where the urine output is less, the patient is looking drowsy, there's a labored breathing and tachycardia, and the patient blood pressure systolic is around 80. What is the likely severity of this particular problem? So you can mention that it's a severe shock. What happens of the effects of organ failure in the lung? It can lead to ARDS or acute respiratory distress syndrome. In kidney, it can lead to acute kidney injury or acute renal insufficiency. In the clotting problems, you can have coagulopathy. Typically, you will have consumptive coagulopathy in such patients, and because of that, the patients can go into an accelerated bleeding, secondary hemorrhage, reactionary hemorrhage, and in cardiac, you will have a cardiovascular failure. What are the ways in which we monitor the patient in shock? The minimum what is required is an ECG, a pulse oximetry, blood pressure, and urine output. These are the things available commonly. This describe and tell you what happens in monitoring of the patient with shock. And in additional modalities, it is always good idea to have a central venous pressure, an invasive blood pressure, monitoring the cardiac output of the patient, understanding the base deficit and serum lactate levels. These are available on your ABG blood class reports, where you can find out what happens with the base deficits and the lactate levels. A complex slide, but this tells you about the pathogenesis of severe sepsis, which happens in patients with infection. Classically, in surgery, you will have a patient with perforative peritonitis, and it will lead to various cellular responses in terms of platelet activation, coagulation activation. You will have the tumor necrosis factor and the interleukins, which are the pro-inflammatory cytokines, which will be released, and that subsequently, if not corrected, can lead the patient into consumptive coagulopathy or DIC, and which can ultimately lead to endothelial damage, multi-organ failure, and death. So, at all these cascades, it's important to understand how we can prevent each one of them. This is a patient in the septic shock. This is from the latest evidence of the survival sepsis guidelines. And you can see here from the right side, you will have patients who have been given antibiotics, vasopressinal agents, enteral feeding, insulin therapy, because all this is to have an ERAS protocol. The patient is sedated deeply. You will have lung protective ventilation, a catheter in place to know exactly what's happening to the internal perfusion of the kidneys. And early cold-death therapy probably would not be the right thing in such patients, but we will try to aim, and the fluid will be in form of colloids and crystalloids. A word about base deficit and lactate. Lactic acid is very interesting. It is generated by the cells who undergo an anaerobic respiration, as we saw earlier. The degree of lactic acidosis is measured by the serum lactate levels. A classical example is if you have a patient with ischemic bowel disease, and if you see the serum lactate levels, it's very high, because that tells you that this patient is into an anaerobic phase or a phase of gangrene. A base deficit of more than 6 millimoles will have a much higher morbidity and mortality than those with no metabolic acidosis. So these are the vital things which tell you the endpoints of resuscitation. So when you're resuscitating a patient and the lactates are very high, and after the resuscitation, if the lactate deficit is becoming smaller and lesser, you know that this is a patient who is getting recovered and is getting better. So this is what is important for you to understand from here. And there is also a concept of mixed venous oxygen saturation. Mixed venous oxygen saturation, the normal levels are about 50 to 70%, but levels below 50 indicate inadequate oxygen delivery and increase oxygen extraction by the cells, and this is consistent with the hypovolemic or cardiogenic shock. So in hypovolemic or cardiogenic shock, this is what will tell you about what is happening. High venous saturation levels, more than 70%, are seen in patients with sepsis and also some other forms of distributive shock, which we saw earlier. In sepsis, there is a disordered utilization of oxygen at the cellular level, and that is the reason there is an AV shunting of the blood. Because of this, you will have high mixed venous saturation in patients with sepsis. This is again a slide which tells you about the systemic perfusion and the way you can make out in what investigation. So you can do a base deficit, you can find the lactate levels and mixed venous oxygen saturation to assess that. Organ perfusion in terms of the muscle, if you want to assess that, today we have technologies like near infrared spectroscopy, tissue oxygen electrode, which tell you what's happened in the muscle, in the gut, a sublingual capnometry or a gut mucosal pH, laser Doppler flowmetry, kidneys, urine output is the best judge, and in the brain, you can also have tissue oxygen electrodes and near infrared spectroscopy. So these are the things which today with the modern era, one can find out about the perfusion. Trauma also leads to a trauma-induced coagulopathy. So it is not always in sepsis that you'll have, but in trauma also you can have a trauma-induced coagulopathy, or what is known as TIC, and this can further get aggravated if the patient has persistent hypothermia and acidosis. So these are the three components of what we call it as a triangle of death. In the center, you will see that there is an energy loss, and one has to prevent this triangle of acidosis, coagulopathy, and hypothermia. So a good intervention in each one of these can prevent of what is going to land up in this particular case. Hypothyroidism in critically ill patients, it will reduce the cardiac output and it can lead to hypotension and respiratory insufficiency. So it is one of the ways in which you have to monitor. Thyrotoxicosis can induce a reversible cardiomyopathy. So these are additional problems, and sometimes acute adrenal insufficiency. So you will find that these patients who are steroid dependent because of some form of oral or IV steroids or some medications which they've been taking, and if they are not given, they can go into severe adrenal insufficiency, and these patients will require steroids to come out of that situation. Let us now focus on the exams or go through some MCQ questions. Mr. Arijit Bhandari, a 25-year-old gentleman working in an automobile industry, he sustained a injury and he underwent an exploratory laparotomy. Now he's on postoperatively day 8. Which of the following is not a part of the catabolic response to injury? So you have the ubiquitin protease pathway, lysosomal cathepsin, mTOR pathway, and the calcium calpain pathway. So the correct answer to this is the mTOR pathway. And you saw that in the initial slide where I talked about that complex slide where this particular part is given. So a patient who has suffered major trauma and emergency laparotomy is always in a state of catabolism with a loss of lean body mass. The patient can lose about 14 to 20 grams of proteins per day, which we told you about 500 grams of lean body mass. And catabolism happens through protein breakdown, which is mediated by various molecular pathways. Some of these are ubiquitin, calcium, and lysosomal, but the mTOR pathway is the one which is involved in protein synthesis. Which of the following statement is not true about response to injury? Genetic variability plays an important role in determining intensity. There is a dose-dependent metabolic response. The role of acquired immunity is limited. Innate immunity plays an important role. Neuroendocrine axis is also involved in response, and the answer is role of acquired immunity is limited. Even innate immunity is the one which only plays a role. So innate immunity interacts in a complex manner with adaptive immune system in co-generating the metabolic response to injury. Metabolic response to injury is often graded and varies with time. The dose of injury directly influences the metabolic response, and there is also a strong neuroendocrine component in the response. Which of the following hormone is elevated in trauma? Insulin, glucagon, testosterone, IGF-1. The answer is glucagon because it is a neuroendocrine axis which leads to activation and increase in the glucagon levels. So on the left hand side is the hormones which are increased. So you'll have ACTH, growth hormone, prolactin, adrenaline, cortisol, and glucagon. And the hormones which are decreased will be IGF-1, testosterone, and insulin. So 3 of them are decreased and the remaining 6, 7 are increased in trauma. Metabolic response to injury consists of ebb and flow phase. F phase lasts for about how much time? So we saw that F phase, then you saw that there was a phase of catabolism and anabolism. So the correct answer to this is 24 to 48 hours, which we saw earlier that it happens in the first 2 days. So this is what we saw in hours. The F phase followed by the flow phase and followed by the recovery. So this happens in the first few hours. So F phase, it is attenuated by proper resuscitation and but not completely abolished. Flow phase or catabolism phase goes on for about 3 to 10 days, and the anabolic phase goes in about weeks. Volume receptors are present in which part? Carotid body, aortic arch, atrium, or kidney? And the answer is atrium. So pressure receptors are present in the aortic arch and carotid body, while volume receptors are present in the left atrium. False. What is false regarding metabolic response to injury? David Cumbersome divided into ebb and flow phase, or F phase lasts for 24 to 48 hours. It is completely abolished by proper resuscitation, and F phase is to conserve the volume and energy stored. And the answer to that is that Sir David Cumbersome divided. So it is answer is C, that it is completely abolished by proper resuscitation. So F phase, as we saw, it begins in 24 to 48 hours, is attenuated by proper resuscitation, but not completely abolished. And the main physiological role of F phase is to conserve both circulatory volume and energy stored. Which of the following is true regarding metabolism following trauma? A, B, C, or D? And the answer is A. So during hypermetabolism, protein catabolism increases by 15 to 20%. Hyperalimentation then leads to increase in the free radical formation. Therefore, hypermetabolism can never be fully abolished, and in many cases may be detrimental. In contrast, what happens in starvation metabolic response is abolished by nutritional supplements. Cori cycle utilizes muscle glycogen and it goes via the ATP consumption pathway. Pro-inflammatory cytokines are 1, 6, 8 are involved in proteolysis, and IL-4, 5, 9, 13, TGF are anti-inflammatory cytokines. Which of the following is not an anti-inflammatory cytokine? And the answer is 8A is a pro-inflammatory cytokine. So these are the anti-inflammatory cytokines which we saw in the earlier slide: 4, 5, 9, 10, 13 and TGF, beta, and the pro-inflammatory are 1, 6 and 8. Which of the following compound is not specialized pro-resolving mediator, SPM? And the answer is Gundesin. A group of local mediators known as specialized pre-resolving mediators, SPM, that include essential fatty acid derived lipoxins, resolvins, protectins and myricins, play a role in return to homeostasis at local level after injury. Jacob Devraj, a 29-year-old bodybuilder who also drives a truck, he suffered a major trauma and then he was kept in the ICU after undergoing a major damage control surgery. There is a significant drop in his albumin levels. We saw those in the hepatic phase reactants, and the following albumins can be attributed to. So it is a decreased production by the liver, increased albumin binding to protein molecules released by catabolism, increased transcapillary escape, or diversion of albumin to more vital organs. And the answer is that there is an increased transcapillary escape, or TER, is said to be responsible for the following albumin levels after trauma, rather than the decreased production by the liver. So it is not the liver which produces less, but there is a migration, and this happens because of the leak, increased microvascular permeability, and albumin transcapillary escape may be increased 3 to 4 fold following major injury or sepsis. So it is a shifting from one compartment to the other compartment because of the microvascular permeability, which leads to this fall in the albumin levels. Ravi Teja, a 56-year-old leading movie star, suffers a major accident. He undergoes multiple injuries. The physician diagnoses him because of insulin resistance because he notices that the patient has persistent hyperglycemia. So which of the following statement is not true? Hyperglycemia is due to increased glucose production. So is it true because of that? Hyperglycemia is due to decreased entry of the glucose, or there is a degree of insulin resistance not proportional to the injury, or pro-inflammatory cytokines play a role in insulin resistance. And the answer is that the degree of insulin resistance is not proportional to the magnitude of injury. So following surgery or trauma, there will be hyperglycemia which happens because of the increased glucose production combined with decreased uptake. So when you have more production and less uptake, the sugar levels will go up. The decreased glucose uptake is because of the insulin resistance, which is transiently induced in a patient with stress. And suggested mechanisms for this include the action of the pro-inflammatory cytokines, decreased responsiveness of the insulin-regulated glucose transporter proteins, and the degree of insulin resistance is proportional to the magnitude of the injury process. Thank you very much. This is a very important module, and one needs to now get back to the text, read these chapters in details from the Bailey and Love and Sabiston, so that you can understand the concepts what have been explained in this particular module very clearly. Thank you very much.